All right, welcome everyone. Thank you for joining us today in person in San Francisco and online. We are thrilled to have everyone here for the day before HRS. And certainly for those of you who can't join us in San Francisco, we're really excited to offer this as a hybrid course. My name is Nicole Dorman. I'm the Fellows Education Manager for BioSense Webster. It is my pleasure to introduce our faculty today, Dr. Warren Sonny Jackman and Dr. Greg Michaud, who will be presenting Complex Cases Simplified. Just a few housekeeping items with Zoom. If you're attending virtually, you can ask your questions through the Q&A feature at the bottom of your screen. And then for those of you here, we'll have opportunity for discussion and to ask your questions then. And with that being said, please enjoy the program. Thank you.
Thanks, Nicole. And thanks to BioSense for making this available. I don't know what it is, but Greg and I love doing this kind of stuff. So it's really an honor, and it's wonderful that BioSense Webster does this. By the way, if you brought your computers, I mean, you can see the screen, it's pretty clear and whatever, but you can actually log on to Zoom. And if you want the screen right up in front of you, it might be clear. You all are so young, it's not a big issue. When you get to be closer to my age, sometimes seeing something up close is actually a big help. So that's your option. You're hearing me okay? Perfect. So I have the morning and Greg has the afternoon. And so we each picked what we wanted to do. I haven't talked about AVNRT in a little while. And it is one of my favorite topics. I'm going to present it in a way that might be a little bit different from the way you've seen it or the way it's been presented. I simply ask that you keep your mind open. This is a rhythm that I've banged my head against the wall for over 35 years trying to get a handle on. You know, we tend to think of this as a very simplistic arrhythmia, and I think when you start thinking of it anatomically, it starts to get a little simpler. So let's work on that a little bit. Okay. Our concepts of AVNRT actually go back to the early 1970s. At Staten Island in New York, at the Staten Island Public Health Service Hospital. This is where they first began to record the His bundle electrogram in humans from the femoral vein, you know, and they started out looking at sinus node function. They started looking at AV conduction, and the first tachycardia that group looked at was actually AVNRT. And they made a couple of very significant observations. And the first and probably most important was with atrial extrastimuli or with rapid atrial pacing, they saw the jump in AH interval that led them to the concept of two AV nodal pathways, or what we call dual pathway physiology. They called those two pathways in the early days the alpha and beta pathways, but that dropped off pretty quick because nobody could remember which one was alpha, which one was beta. And so the one with the short conduction time became the fast pathway, the one with the long conduction time became the slow pathway. So this concept of dual pathway physiology emerged very, very early on in that time. The second observation, in those days, they used 3 catheters in the very early days. So one was sinus node testing. They put a catheter in the high right atrium near the sinus node, the His bundle region to look at AV conduction, and the ventricle to be able to pace the ventricle. And what they noticed in AVNRT was that they could dissociate the high right atrium from the tachycardia. They could put atrial extrastimuli in, and it wouldn't affect the tachycardia at all. So they made several assumptions from these 2 observations, right? The first is they assumed if they could dissociate the high right atrium, that they could that all the atria were dissociated. That was an assumption, okay? Turned out not to be true, but it was reasonable and very reasonable for the day. Okay, they assumed that the atria were not part of the reentrant circuit, so that led them to believe and form the hypothesis that the reentrant circuit they thought was actually inside the AV node itself, confined to the AV node. In other words, the fast and slow pathways were located inside the AV node. And when you look at the AV node, it's just a jumble of fibers, and there was no obvious anatomic area for it. So they assumed that it was a functional separation of the tissue into these two pathways, and they called it the term that you've heard many times. They called it functional longitudinal, meaning, I guess, dividing it, going from proximal to distal, I guess is what longitudinal means, I don't know. Functional longitudinal dissociation of the AV node. And they made this gorgeous model, okay? And in this model, right, so both pathways are located in the AV node, the fast pathway and the slow pathway. And they said that the AV nodal tissue here between the proximal junction of the two pathways and the atrium, they call that the upper common pathway, okay? And the AV nodal tissue between the distal junction of the two pathways and the His bundle, they call the lower common pathway. Now, I actually saw this presented in 1978. I was a resident in internal medicine, and I was getting interested in electrophysiology. This is before my cardiology training. In the US, I know we have a lot of people here not from the US. In the US, we go, after medical school, we do residency in internal medicine, then a cardiology fellowship, and then an EP fellowship. But so me and two other guys, we drove up to Bethesda. The American College of Cardiology had their very first they called it the Heart House course. They had a series of courses and was the first one on electrophysiology. And it was run by Ken Rosen, who was from Chicago. And he presented this model, and my eyes were like this. I mean, just buggered up wide. I just thought this was the neatest thing since sliced bread. And this model was widely accepted around the world by all electrophysiologists as the mechanism of AVNRT. And it stayed that way all through the 70s and into the 80s. But some information started to arise in the 1980s that didn't quite fit this model. And the first is what I think is probably the most important paper ever in AV node reentry. Rui Sung and his colleagues, when they were at the University of Miami, and actually they had trouble publishing this paper. Folks didn't believe this. One of them was one of my heroes also, John Gallagher, who formally admitted at a meeting once that he rejected this paper 3 times, and said, "I'm sorry about it," you know. But what they did, okay, they had patients with AVNRT, and they did ventricular extrastimuli. And with the ventricular extrastimuli, they saw a shift from retrograde fast pathway conduction. FP is going to stand for fast pathway for this talk, and SP slow pathway. So they saw a shift from retrograde conduction over the fast pathway to the slow pathway. And when they did see that jump in VA interval, they were very surprised to see a shift in the site of earliest retrograde atrial activation from the His bundle electrogram to the proximal coronary sinus. And this wasn't, I can tell you this, I was an EP fellow. I was finishing my EP fellowship. This paper came out 1 month before the end of my EP fellowship. And I remember asking someone who will remain nameless about this, who said, it doesn't make any sense, don't worry about it. But this bothered me. And it continued to do so. Because what is this telling you? This is telling you that the fast pathway and the slow pathway have separate connections to the atrium. They connect separately. So there is no upper common pathway in AVNRT. Okay, there just isn't based on this. This is 81, but again, it actually didn't get very much attention at the time. Then in the mid 80s. So there's no upper common pathway. So in the mid 80s, around the world, there were 3 different open heart surgical procedures that were developed for curing AVNRT. Okay, ablation of AVNRT had not started yet. Selective ablation of AVNRT had not yet started. And so there were three surgeries, different surgeries, and they were so wildly different. I don't want to go into them because, first of all, I'm not sure I totally understood one of them. But the surgeons operated not on the compact AV node, but outside that area. And all three of these procedures got rid of AVNRT, and they did it without affecting the PR interval. So presumably the fast pathway was intact. So operating away from the AV node must have affected the slow pathway. And what does that suggest? That suggests that the fast and slow pathways are actually anatomically different. Okay, then comes the late 1980s, right, with catheter ablation, all right, and we selectively targeted the slow pathway in the inferior septum, that space between the tricuspid annulus and the coronary sinus ostium. And what that said was, and that selectively affected that slow pathway in AVNRT. So that said that there's part of the slow pathway that's located very far away from the AV node, very far away from the AV node in that inferior septum. Okay, so these things are coming together, and this model is starting to get shakier and shakier. But there were some real important anatomic considerations of the AV node that had not been paid attention to when this model was created. The first is the AV node is very small. It's a few millimeters oblong in its length. And if you look at it anatomically, there are these little fibers that are slowly conducting fibers that are separated from each other, and they're all jumbled up in there. They're not like, they don't flow in a direction like atrial fibers or ventricular fibers. They all go every which way, and there's fibrous tissue in between and everything. And you look at that and you say, well, there's no possible way that could functionally separate into pathways with fixed conduction times. You know, every time you start the tachycardia and stop it and start it and stop it and start it and stop it, it comes out the same each time. If the pathways were in that, you can't, there has to be a relationship between anatomy and the physiologic behavior. The second thing that was missed is the AV node doesn't touch the atrium. The AV node itself is not in contact with the atrium. Okay, so there is no space there. It's not in contact. The atrial impulse activates the AV node. Otherwise, we'd be putting pacemakers in everybody. Well, I guess we wouldn't get that far, but some would have had to happen, I guess, different. But the atrial impulse has to get to the AV node, and it does it over bundles of fibers that are halfway between atrial fibers and AV nodal fibers. They're called transitional cells. And when you're near the atrial end, these fibers are more like atrial cells. And as you get closer to the AV node, they become more AV node-like and slower conducting and things like that. So what we know today, as beautiful as this model was and as in love with it as I was, what we actually know today is that the AV nodal pathways are actually not in the AV node. The AV nodal pathways are these atrial nodal connections that come in. And there's actually, we know of 5 of them. I may be aware of 2 patients that have a 6th one, but I haven't, the last one I heard about was about 3 years ago, and the one that somebody showed me one, and I saw one that was in the same place that's not one of the 5 about 4 years before then. So, you know, it's got to be rarer than hen's teeth, but basically there are 5 that we know about that are anatomically discrete. They're in the same place, roughly the same location in different patients. What am I supposed to say? That the interpersonal, there's little variation, interpersonal variation, or what's the right wording for that? That they're kind of the same place in the different people. You have to, my vocabulary is not very good. I actually dropped out of college so I wouldn't have to take my English requirement, and went to medical school so I wouldn't actually have to take it. The joke was not on them, on the college. Their joke is now they look at me now and say, see, look, the idiot left, didn't take his English. All right. So there's 5 atrial nodal connections. One is the fast pathway, and the other 4, and I'll show you why that's different than the other 4. The other 4 are lumped under the category of slow pathways. So obviously the most common, the usual slow pathway is actually the rightward inferior extension of the AV node. The next most common is the leftward inferior extension of the AV node. And then you have 2 uncommon, or when I say uncommon, I don't know how often they're actually anatomically present, but conduction wise, we don't see them. We don't see them actually very often, and we're going to talk about that in a little bit. So almost everyone has conduction over the fast AV nodal pathway and the rightward inferior extension. And in a little while, I'll show you some evidence why I believe that about 75% of people also have conduction over the leftward inferior extension. So dual pathway physiology is normal. We actually all have it. It's hidden by the fast pathway. If you put patients asleep, in something like 85% of patients, you can see dual pathway physiology, antegrade or retrograde. Okay, if you put them deep asleep, if you give them just a tiny bit of isopaternol, the retrograde is hidden in almost all patients, and sometimes even the antegrade can get hidden. But it's not a pathologic diagnosis. We all have these multiple pathways. This is normal anatomy. We all have that. Okay. Again, these 2 are relatively uncommon, and where we see them most often are when patients are referred to us after a failed ablation. That's typically where we see them, and actually, they're not super rare. They're kind of uncommon, but they're not super rare. We need to know they both of these exist to find them in those patients when they're referred to us. Okay, so how do we know these exist? How do we know there's all these different ones? And how do we know where they're located? You know, how do we find them? Okay, we find them by their atrial end. Obviously, they're all going to come into the node, but we find them by their atrial end. So if we look at retrograde conduction, they each have a unique site of earliest retrograde atrial activation. So I'm going to use this cartoon several times today or this morning to talk about location. Okay, so this one is the septum in the RAO projection. So this is the tricuspid annulus. This is going to be the tendon of Todaro and the eustachian ridge, coronary sinus, his bundle, AV node. The other day, Sonny Poe asked me why I have a space here in between, and I said because I forgot to put it, to put these together. So don't ask why. It was a dumb drawing. I drew these myself, and I don't, it's harder to put things together on a computer if you can't draw. And in the LAO, this is the base of the heart. So this is the mitral annulus and the tricuspid annulus and coronary sinus ostium. All right. So if we look at retrograde AV nodal conduction, there's going to be 5 different locations that we can see retrograde activation of the atrium. So during retrograde AV nodal conduction, if the site of earliest atrial activation is located here, posterior to the tendon of Todaro and the eustachian ridge, and inferior to the site where you record the most proximal His bundle potential, that's retrograde conduction over the fast AV nodal pathway. Okay, if the first signal that you record retrograde is located here between the tricuspid annulus and the coronary sinus ostium, okay, this is retrograde conduction over the rightward inferior extension. Again, if somebody says the slow pathway, what they mean is it's English worse than my own English if they do that, but if they do say that, they're talking about the rightward inferior extension. Or if they say the slow pathway area, obviously, as you know, it's the area for the rightward inferior extension. Okay, if earliest retrograde atrial activation is recorded in the roof of the coronary sinus, about 2 centimeters in, if you measure it from the roof of the coronary sinus ostium, that's retrograde conduction over the leftward inferior extension. And if the earliest retrograde atrial activation is in the left atrium, and it's at the base, it's close to the annulus, and it's between 4 and 5 o'clock, it's usually dead on 4:30 o'clock, almost always dead on 4:30 o'clock. Okay, we call that, we made up the name, and it's a terrible name, but we use this name so people don't mix these two up. And so we call this the infralateral left atrial slow pathway. It's kind of hard to miss the location if you call it the infralateral left atrial slow pathway. Maybe we should have called it the basal infralateral left atrial slow pathway. Then it would be absolutely impossible, right, to mix it up. And then the final one, the rarest of them, and it may be more common in Asia because there are more reports of this in Japan and in China, is located here, posterior to the tendon of Todaro, but instead of being inferior to the level of the proximal hispundal potential, it's actually superior to that level by just a little bit, okay? And we call that the anterior superior slow pathway. So these are the 5 AV nodal connections. In a sense, these are the atrial ends of the 5 AV nodal pathways. And look how close to the AV node they are. They're not close. They're actually pretty darn far away. And that's really nice because you can ablate them staying very, very far away from the AV node. Well, not this one you don't want to ablate, okay? But these others, right, you can target them very, very far from the AV node with actually a very, very low risk of AV block. So we've got 5 of these, and that's 5 factorial. The number of combinations that you could have using one of these pathways antegrade, one of these pathways retrograde is a ton of time. It's actually 20. There's 20 combinations, right? There's 20 combinations. We've actually seen 9, and we're going to talk about how you put these together to make AVNRT in the next presentation after the break. What I want to do before the break is I want to review each one of these one at a time and look at these, where they're located, how to find them, and for the bottom 4, how to target them far away from the company. Did you have a question? Oh, you're just confirming. Got it. No problem. That's great. All right, so let's start with the fast pathway, the one we don't want to kill. So sometimes you have to know as much about what you don't want to hurt in order to avoid it. So the fast AV nodal pathway is formed by cells, transitional cells, bundles of transitional cells, these green lines, that attach the right side of the septum and go around the right side of the tendon of Todaro, and also bundles that attach the left side of the septum and go around the left side of the tendon of Todaro. If you look at the old literature from the 70s when they tried to understand the AV node in that old conduction system of the Hart-Wellens' book and things like that, they called these the superficial and deep. So they were talking about, because they're looking at the heart like this. So the superficial would have been the right-sided and the deep would have been the left-sided fibers. And if we look at retrograde conduction over the fast pathway, so why is the fast pathway listed separate from the other ones? And it has to do with where it inserts. So the fast pathway inserts pretty high, okay? It bypasses much of the compact AV node. And this is the reason we have a short AH and for antegrade conduction, right? Sinus rhythm, atrial pacing, whatever. And during retrograde conduction, AVNRT with retrograde fast pathway or ventricular pacing, we have a short HA interval. Okay, it has to do with where it inserts. And obviously the ones we're calling slow pathways, they're obviously going to insert not there. They're going to have to go through the AV node and add the AV node to their conduction time and the decrement to their conduction time. So the greater decrement, the greater conduction time, a lot of that comes from the node itself. Does that make sense to everyone? Okay, so if we look retrograde, the site of earliest atrial activation is going to be down here. And there's two things about it that's critical that you should keep foremost in your thoughts. The first is that it's always located outside of the triangle of Koch. It's located behind the triangle of Koch. So a way to say that would be posterior, meaning this direction, to the tendon of Todaro up here and the eustachian ridge. Okay, and the second observation, let's stay with that first observation for a second. So how do you recognize when you're behind the tendon of Todaro? It's actually quite easy. So if you have a catheter on the His bundle or a catheter in the ventricle at the anterior septal area here in the ventricle, it's going to be laying across the triangle of Koch here. Okay, if you're behind so if you were to look in the LAO, right, if we set the LAO, this back here on these fingers would be the tendon of Todaro. Okay, so that catheter is going to be there. If you go behind the tendon of Todaro towards my body, if you go behind the tendon of Todaro, the catheter goes like this. So in the LAO, that catheter is deviated leftward. Okay. All right. Now, the second thing to keep in mind of where the atrial end of these fibers are, the second thing to keep in mind is that it's inferior to the site where you record the His bundle. You're going to hear me say that many times because we're going to differentiate it from the anterior superior slow pathway based on where it's located back here. Okay. All right. So to look LAO, everybody's LAO angle is different. There is no one LAO angle. I don't have a standard LAO angle. What I do is I put the His catheter flush against the triangle of Koch, meaning all the electrograms are sharp. If the proximal electrograms are small and rounded, it means it's off the septum. Is that logical? Okay, so you want all the electrograms to be sharp, flush. And then I set my LAO angle, so I'm looking straight down here. It doesn't matter what the number is. Okay, that's your LAO. That's your LAO angle. Okay. And then when we're mapping retrograde conduction, if earliest activation is here, do you see how far leftward this is? I mean, this would be the line for the septum right here. So look how far leftward we are in the LAO projection. Okay. And so that tells us, because we're leftward and inferior to the site recording the proximal His bundle potential, which was on this. You don't have to. Mia is going to send you a PDF of all the slides. So these slides it'll save you the trouble. You're welcome. Okay. So it's really obvious when you're behind the tendon of Todaro. You see how leftward that is, and if we're doing this fluoroscopically, it's exactly the same thing. So we've got the His over here, the His and proximal right bundle over here, and here you can see. Look how far leftward we are in the LAO. Once we've set the LAO on Cardo, we use the same angle. If we ever turn fluoro on, sometimes in adults we might. Usually in the kids we don't. But if you do, if you've picked your angle on the LAO on fluoro, if you happen to pick it, we just use that same angle in the mapping system as well. And you can see how far leftward. Look from here to here. Does that make sense to everyone? How to recognize when you're behind the tendon of Todaro? That turns out that's really important tool. Okay. So the second thing I said was that this site is always going to be inferior to the site recording the proximal His bundle potential. You'll see these electrograms on the next slide. We recorded the proximal His. Right here, we have a little bit of an A on this electrogram. So this is more proximal than usual. And you can see if we look, this site is 1.2 centimeters inferior. This would be your absolutely typical fast pathway location. Okay, so let's look at the electrograms. So here's the mapping catheter on the septum. Here is the distal bipolar electrogram. And you can see that this was the site of earliest activation. Now it has two components. And so you say, well, maybe this was the local. I'm not giving you the unipolar. I'll show you that in a subsequent slide. But the unipolar begins as a steep negative here. So this actually is the activation time. This is really where activation is beginning, right at the beginning here. Now, on a bipolar electrogram, we typically take the first rapid as the local activation time for a bipolar electrogram. So on the His bundle electrograms, okay, we would measure that here. And you can see that actually that measures 12 milliseconds later than the actual earliest activation. So it took 12 milliseconds to get from here to here. Make sense to everyone? What's neat is these electrodes, these bipolar electrodes, can see this far. But when you get farther away, what does the electrogram look like? If activation is farther away from your electrode, what happens to the electrogram? Gets smaller and rounder. You lose all the sharpness to it. So sharpness, the steepness of the slope, corresponds to closeness. Okay, so the activation is going to be the first rapid crossing point. Okay, all right. So you can see from here, from the His, you can see this location, but it's going to be rounded here. You see that? We call that the far field part of the electrogram. The very beginning, before activation gets to that electrode, and you can see it's almost the same time as activation. So if you look in your His bundle electrogram where that signal is beginning, correlates reasonably well to roughly the onset of retrograde conduction over the fast pathway, the earliest activation, I should say. Okay. All right. I mentioned to you that the fibers go from the right side of the septum here. They also go from the left side of the septum. You can look at this in patients that have a PFO, and a number of groups have done this. We did it. There's been probably 4 or 5 other groups that I know have looked at it, which means there's probably been 500 people that have looked at it. And you can see that activation begins roughly the same time on both sides. So here is an old example, an early example in a patient that had a PFO. Okay, so notice here's our His. Do you see our LAO angle is pretty good? We're looking straight down the His catheter. Everybody appreciate that? Okay, so here was the right-sided mapping catheter, and look how far leftward it is. That tells you, what does that tell you if it's this far leftward? Well, just the fact it's leftward, what does that tell you? Tells you behind. Yes, you were right, but I was actually looking for that other answer. And the answer was that it tells you you're behind the tendon of Todaro. That's right. And here was the mapping catheter on the left. So here was the right-sided mapping catheter. Here was the left-sided mapping catheter. But actually, when the electrograms I'm going to show you, we didn't want to take another picture. This catheter was actually down here. And that's right at the typical fast pathway activation site. Right here. So here are the electrograms. So here's the His bundle electrogram. So here's the His, the A, and the local V during slow fast AVNRT, meaning retrograde conduction over the fast pathway. So here you see the timing of the His, and here you see the timing of activation on the right side and the left side. And they're sort of similar, but almost everybody that's looked at this always says, you know, it looks like the left side is a hair earlier. You get the feeling when you look at these. Now, these are not high resolution electrodes. These were ablation catheters. So these are very big electrodes. It's not a good way. It needs to be done meticulously with very high resolution recording electrodes. Not that it's actually important to do, because basically, as long as you understand that both sides are being activated, both sides are being activated. And the fact that the left looks earlier to almost everybody that's done this may actually be real, because there's a lot of observations, individual case observations. I'll show you one of them in the second talk, that suggests that retrograde conduction is primarily going to the left side of the septum, are the left fibers for retrograde conduction. Sometimes I get the feeling that antegrade is right-sided. Sometimes you can definitely make heart block from the left side. There's no question. So you know, I'm not positive, but definitely retrograde conduction seems to be on the left side. So the whole idea is both sides get activated. That's what I want you to understand and take from this. Okay. And obviously, they're both going to be earlier by at least 10 milliseconds than the timing of the His bundle electrogram, the local activation in the His bundle electrogram. Okay, so this is the site of earliest retrograde atrial activation, but how is the triangle of Koch activated? How is the triangle of Koch activated? Does anybody know if it's early or late or whatever? Anybody want to guess? Well, we didn't know. So when CARTO became available, we kind of wanted to use it to look. But in the early days, there's only a few of us here who will remember what the electrodes were like in the early days, right? So we looked at this back in 2000, and at that time, only the ablation electrode could you actually make a map with CARTO. So Will Webster, who made all the tools and the catheters that we use, the spacing and everything going back 35 years ago. There wasn't anybody else that would make small electrodes closely spaced. He was the only one that would. And when you said, I think this is important, he would usually put it in the mail to you the next day. He was really something else. I miss him. So what he did is he took one of these catheters and he sliced it into, took the electrodes, sliced it into 4 electrodes and put wires on them so that there were 4 electrodes here. And they were separated by less than ½ millimeter. So the bipolar electrogram, remember, you're really looking primarily at the space between the 2 electrodes. Very, very, very high resolution. And the good news was in those days, we used to reuse our catheters. If they didn't have a lumen in them, we could gas sterilize them. We'd clean them up, and I never did it. So I mean, the nurses did it. So I'm not sure. They would use some kind of Sidex or something on there, and then they'd pack them into a special bag and they'd get gas sterilized. And then the next day you could use them again. And we used to use them until the electrodes died, until they were broken. So we got 7 out of this. So we used this catheter in 7 of the patients. Now, mapping atrial activation during slow-fast AVNRT is a bit of a problem because the atrial and ventricular activation is simultaneous. And being sure what's atrium and what ventricle can be very, very, very difficult. So what we did instead was we made the maps during ventricular pacing where we would pace in the anterior septum, we pace the anterior septum, but where we don't capture the right bundle. So it's the same site like parahisian pacing where we don't capture the His. And that delayed and here you can actually see it. Here's the RV site is a little bit off the septum. So it's a little away from the right bundle. Can you all appreciate that? So it didn't capture the right bundle. And so it delays the timing of the His, and that lets you see the entire atrial activation sequence, and you don't have to worry about mapping. So, but when you do that, you have to compare all the electrograms during tachycardia and during ventricular pacing and make sure they're all identical, that you're really looking at the same pathway, and that's what we did. And you know, we were able to find the earliest day, and you can see the unipolar does begin steep. The problem is here's the T wave on the ventricular potential here that makes it look like you're getting something else here. But that's it. Okay, so we were able to do 7 patients. And here's one of these maps. And what we did is we mapped kind of the septal third of the right atrium and the coronary sinus. And I'm showing it to you here in the steep LAO projection. And I just put these lines here to make believe where the rest of the atrium would be, if you know, in case this is kind of awkward to look at. And notice there's a ridge here What do you think that ridge is? If this is the location of the proximal His, what would the ridge right behind it be? Nobody? Yeah, both of those are correct. It would be the tendon of Todaro and the eustachian ridge. That's right. Up high, they're the same structure. It just has two names in two different parts. So when it's deeper, buried underneath, as it goes toward the membranous septum, it's called the tendon of Todaro. When it kind of sticks up a little higher, but it's the same piece of tissue. It has three names, right? Up high, it's the tendon of Todaro, then the eustachian ridge, and then the eustachian valve, where it goes in front of it's all one piece of connective tissue with three names. Well, I have two names, so I guess it's okay to have three names. All right, so this would be the tendon of Todaro and the eustachian ridge here. So let's get rid of these silly lines here. And so the earliest activation is going to be on the true septum back here. We could get it up against the ridge here, and we could get the catheter back here. We couldn't get it here in the middle, and to get it to be stable and get an electrogram. So basically what you have is you have all these sites around here with the same activation time. So what does that tell you the real earliest is? Does it mean it's here or here? In the middle. It has to be somewhere in the middle. So let's say earliest activation is going to be about there, and you can see that activation propagates inferiorly along the septum, and then it blocks at the tendon of Todaro and the eustachian ridge. Now, we didn't map the left atrium, but we can imagine, from what we know from other patients, we can imagine where the left atrium is. So I'm going to show it as a black arrow. So the left atrium is activated at the same location on the deep side here, on the left side, and it's going to run down here and go around the mitral annulus. Okay. Now the left atrium and the coronary sinus are actually richly connected. Let me show you a figure. This is one of my favorite figures from a friend, Ton Becker, a retired master anatomist, pathologist, researcher for many years. Anton Becker from the University of Amsterdam, from the Academic Medical Center in Amsterdam. And he made, beginning in the late 80s and early 90s, he made a huge effort to try to correlate the anatomy with what we were seeing electrophysiologically, just like Dr. Ho does these days. But Ton was really the first one to really pick it up and try to make that correlation for us. And this is a picture. We used to do a program together, and everything was on 35mm slides in the old days when we gave talks. And he used to let me take one of his 35mm slides home after every meeting. And when I saw this one, I knew the one I wanted was this one. And so what we're doing is we're looking at the coronary sinus from behind and from the foot. Is everybody oriented? Okay, so this is the left atrium up here. This is the left ventricle. The right atrium is over here. The right ventricle is over here. Everybody okay with that? IVC, inferior vena cava, is here. And here you see the coronary sinus. So here's the great cardiac vein, the Marshall vein, the posterior coronary vein. There's no muscle on here. But look at the coronary sinus. It has a rich coating of myocardium. Von Ludinghausen calls this the CS, the coronary sinus myocardial coat. It has multiple layers. These fibers conduct an impulse just like atrial myocardium does. Okay, it can conduct an impulse, and notice it's richly connected. This is left atrium. This is the CS myocardium. You see it's connected here. It's connected here. Look at the septum. There's a very rich connection here. Can you appreciate that? So can you see how if the left atrial septum activation is coming down the left atrial septum, you could easily see how it could enter the triangle of Koch through the CS ostium, right? Okay, so when the left is going around here, it's going to activate the CS, muscle. So the CS myocardium is going to be activated. It's going to go distal, but it's also going to go proximal. And it's the CS myocardium that activates the triangle of Koch. So the triangle of Koch is activated very late because you get the left atrium very early. It has to propagate away. It has to activate the CS muscle, and then it has to come in here. And then conduction here, the signals are very sharp. As you get higher, the signals get very small and rounded, and then you can't see anything up here. That's why you just have this green color, which is interpolation. You see there's no points here, right? So when you make your cartomaps these days, a lot of people like to turn off the points and just show the colors. Don't ever do that. Always leave the points so you know where there's real information. There is no information here, right? So there's nothing there. And notice once you get past here, you can't record anything here. So what's in this location right here? What is the structure that's in this location that I'm drawing, this ellipse that I'm drawing? Correct. Compact AV node. That's it, or the AV node. I guess they're the same. Sometimes we say one, sometimes we say the other. I don't think there is, actually, that's the wrong name. We call it the compact AV node, meaning as opposed to the transitional fibers that'll go there. That's what they mean by compact AV node. But if you look at the AV node histologically, it doesn't look compact. And well, it's all crazy. The fiber orientation and everything in there. Anyway, so it's the real AV node is right in here. So this is late. It's actually very late activation. So early activation back here, late activation back there, that's retrograde fast pathway. So if we look at, you haven't seen one of these old propagation maps that are 22 years old, okay? So here's earliest activation. It's going to be propagating here. It's propagating inferiorly. The left atrium now is being activated, and it's going to activate the CS. The CS is going to activate the triangle of Koch and the triangle of Koch. Let me do that faster so it makes a little more sense. You all see that kind of coming around like that? Okay, so if we were to look at retrograde fast pathway, right, the fast pathway is going to activate the right atrium and the left atrium, both. And I have this as dashed lines because we don't record anything here. We don't record anything. So usually we're mapping, we have catheters on the right side and in the CS most often, right? And so the earliest activation we're going to have, atrial activation is going to be in green. So this would be the earliest activation, and then right atrial activation is going to propagate away, but it's going to block here. It's going to block here, and it doesn't come in here. And that's the reason in slow fast AVNRT you can dissociate the right atrium. But the only atrial catheter they had was in the high right atrium. So that's the only place they dissociated. They didn't look on the left side here in the proximal CS or near the septum here, because while you're activating the right side, you're also activating the left side. The left atrium in green is going to propagate around the mitral annulus. And then you have all those rich connections between the CS myocardium and the left atrium. And you've got this big one here right at the beginning as this comes around that's going to activate the CS in both directions. The CS is then going to activate the triangle of Koch. And we make up a name for this area. We made up a name for us so we could use it. Creed, did we make this thing up when you were still there? Did we call this the inferior triangle of Koch in those days? No, you were gone by then? Thank goodness for you, right? You were happy to be gone? Creed, what years were you in Oklahoma City as a fellow? No, or count you, when were your research years with Ben?
5 years here, starting in 86.
So you were with Ben which years? The first 3 or first 2?
First year with Ben and then Freddie Ellen.
Okay. And you left in what year?
91.
91. Okay, cool. All right. So we've made up a name for this spot so that we say we'll put the catheter at the inferior triangle of Koch. It's just a quicker way of saying that, and we abbreviate it this way: for inferior triangle of Koch. And so when you see the electrograms labeled this way, it means the catheter was positioned in this space here. Okay. And so it's going to activate that. And there is a sharp electrogram that you record here. And we made up a name for that one too. And we called that the ASP potential. And that's what we always called it, the ASP potential. And then the signal gets to where you begin to lose it. And you can't record very much. You can't record very much up there. Okay, so the key is this electrogram is late. Early back here, late here. Okay, and let's look at it. So here's the catheter at the inferior triangle of Koch. This is our favorite place. If the floor of the CS os is here and the roof is here, can you see we are right at the middle, right at the middle? And this is where we try to do most of our work and our mapping and various sorts of things in this area here. And you can see the ASP potential, and you can see how late it is. In this case, it's 55 milliseconds. If we assume the beginning of this far field part of the potential is where fast pathway activation is beginning, right? It took 55 milliseconds, and sometimes it's 70 milliseconds that it takes to get around the left side into the CS and come out of the CS and give us this signal. Okay, so so this signal here is going to be very late, and that sharp signal, you see how sharp it is that ASP potential. Now, the catheters that I'm going to show you on those electrograms that we just looked at, the catheter comes from the internal jugular approach. So it's on the floor of the CS, which is pretty far from the left atrium. So the left atrial signal is going to be a little bit far field here until the CS muscle gets activated as it comes around here. So as the left atrium is coming around here, you can actually see the left atrium is a far field signal until you get the CS muscle potential, because we're on the floor, far away from the atrium. Okay, and then you can see the CS propagating back this way, and then 15 milliseconds later, the ASP. So you always know the ASP. It's going to be the potential that's after the timing of activation in the proximal coronary sinus. But notice there's a second potential there. And almost always, when you record with an ablation electrode at the inferior triangle of Koch, you get two potentials. And when we switch the rhythms, you can see the order with different pathways, the order of these potentials can be reversed. But you always have a rounded far field signal, we'll label AFAR, and the sharp component that we're going to label the ASP potential. And the reason is that the bipolar electrogram, the distal bipolar electrogram, has a huge recording range. This is how far you can see activation. And we've actually measured it. It's massive. It's 2.3 centimeters. Okay, so more than a centimeter from the center of that bipole between the electrodes, you can see activation. So you're going to see activation in the inferior triangle of Koch, and you're going to see a little bit of the activation behind the eustachian ridge here, and that's where the far field signal's coming from. And we couldn't figure this out for a number of years. I haven't thought about this in a long time. I'm trying to remember the fellow's name who was working. He was from Westmead at Sydney, Australia. Mark, what was Mark's last name? And he was working in Amsterdam with Giel Janse, and they were mapping like this, and they showed that far field component was coming from behind the eustachian ridge, and then it kind of made sense to us. What was Mark's last name? He went back to Westmead. He went back to Australia. Oh, shoot. Hey, I'm 70. I'm allowed, right? That's a senior moment. It's okay. I know him. I have a picture. I'm looking at his face in my mind. A good guy. And it was really, really helpful. Oh, thank you for reminding me. All right. So that far field signal is coming from back here. So what you're seeing is your electrodes are here, and you're seeing all the way back here. So the atrial activation back there is a far field signal that you're getting. And then the late signal is the sharp signal. Does that make sense? Why you have a far field and a local? They're actually coming from very far. There's a line of block between them. right? The eustachian ridge. Okay, this line of block right here between them. Okay, all right. So we looked at these 7 and we found this block at the tendon of Todaro and the eustachian ridge, and we said that explains AVNRT. It's a piece of cake, right? You have retrograde conduction over the fast pathway here, activation here, coming back in here, and so you have fast pathway, atrium, slow pathway, AV node. Perfect. This is why people have AVNRT, piece of cake. We were so excited, I can't tell you. And then we started looking at people who don't have AVNRT. And we mapped their retrograde fast pathway. And it's absolutely identical. Do you remember the movie My Cousin Vinny? Anybody know My Cousin Vinny? Right? Do you remember the prosecutor when she's, right, you did it perfect, right? Identical. And so people without AVNRT have the identical map, which means they have block here, and they don't have AVNRT inducible, which means we didn't discover what the mechanism, why people have AVNRT. All it left us was confused, because then the question changed from why do these people have AVNRT to why doesn't everyone else have AVNRT? Maybe one person in this room might actually have AVNRT, but most of us don't, right? And we have the exact same anatomy, and the reason is that there's a line of block on this fibrous tissue here. This tissue comes up here and attaches and stops, and this tissue comes up here and attaches and stops. So it's real easy to see why you have block here. The part I've never understood, and I do not know the answer to, is why it doesn't come back in through here. Okay, in flutter, it does. It goes out of the triangle of Koch, right? In flutter, it comes up through here and goes through here. But it doesn't go this way. And it doesn't do it in anybody. I've looked at this and can't tell you how many, hundreds, more than hundreds. And nobody goes this way. Nobody goes from here across the atrium into here because of this eustachian ridge. So everybody should have AVNRT. The question to me has never been, or has lately, is not why does Joe have AVNRT and not Sam? You know, it's more why doesn't Sam have AVNRT? Okay, so I just want to conclude here with the location of how inferior the earliest day is. So this was a non-fluoroscopic case. We had FAM on here. We shouldn't have it, but we took the FAM off, erased the FAM after we made the map, just to show this was earliest activation. And look at all these points up above it. They're all later than the earliest activation. So clearly the earliest activation really is 1 centimeter to 1.5 centimeters inferior for the fast pathway. Now, what I forgot to mention to you is children. If you work with kids, and we do both, we have 2 pediatric electrophysiologists, and we do the kids together as well. Sometimes in children, the earliest day on the fast pathway can actually be higher in very small kids, little kids, young kids. It can be a little higher, but I haven't seen it above the level of the His, and that's important. And again, you're going to have very late activation in here where you record the ASP. Can you do this really quick? Actually, you can do this really quick. This is a clipping plane. Are you familiar with that? Basically, it lets you look inside a map so that you can get rid of the free wall here in the RAO so that you can see inside. And here you can see you come up from below, it gets earlier. You come right up against near the tendon of Todaro. It's earliest. You go higher, back here and higher, it gets later. This is retrograde fast pathway, right? And here you see the bipolar electrogram, and here's the map 1, the distal electrogram. It begins at exactly the same time. All of this other stuff there is part of the V. That's the reason it's hard to map the A, because the A and the V are simultaneous. Do you all see that? But you can actually see the unipolar electrogram actually does begin as a steep negative. We knew that when we paced the ventricle and got rid of the V, that the A actually begins sharp here. Okay, the last point of the fast pathway, is that you can screw up your case by bumping it. It actually is pretty bumpable. Remember, those fibers go around the tendon of Todaro, and the antegrade fibers, I really think the right side is dominant antegrade. If you push your catheter against the tendon of Todaro, you can compress those fibers, you'll get an AH prolongation, you'll lose retrograde fast pathway conduction, and you can't induce AVNRT for a while. And you got to be careful because you like the fast pathway there when it's time to ablate the slow pathway. So you don't want to bump that. So the clue is, or the trick is to come up gently, slowly, and stop when you get very close to the tendon of Todaro. Don't push it across to this side, okay? The other thing is be careful when you put your His catheter, right ventricular catheter and everything. You don't want to just push it across like that. You can do a number of things. You can go counter, right? He was just doing that. He just did this. So you can go counterclockwise and cross. If you're using deflectable catheters, I like to use deflectable catheters for my RV and His. I like to cross low, go up into the ventricle and come back. And I like to leave the His catheter a little bit on the ventricular side so it doesn't come back and bump it. But it's much more bumpable than people kind of appreciate. Okay, so let's go to the, so this is, I spent half the time on, or not half the time, but well, close to it, on the pathway we're not going to mess with. Because I want you to have a really good feeling for it, know where it is, know how to look for it, know how to identify it. Okay, so let's start on the slow pathway. So without a doubt, the dominant slow pathways, the most common slow pathways in all forms of AVNRT are the rightward and leftward inferior extensions of the AV node. And in fact, so here is another fabulous figure. This was another one of his slides that he gave me. The publication is in black and white. There's no color slide. So the color slide is really cool. If anybody wants it, I'd be happy to share it. But make sure you always put Tan's name on it though. So here is the compact AV node. Antegrade conduction over the rightward inferior extension goes like this. Antegrade conduction over the leftward inferior extension goes like this. Here is the compact AV node. And without a doubt, if you took every patient with every form of AVNRT, the most common slow pathway that's going to be involved, right, is the rightward inferior extension. And because it's so easy to kill, this is the reason, and most forms of AVNRT are going to go away. This is the reason we've learned so little about AVNRT. Sonny told me the other day that there was a time where there were a bunch of people that applied for NIH grants to study AV node stuff for AV node reentry. And the reviewers rejected all of them saying, we don't care, it's too easy to get rid of and whatever. So I actually wasn't aware. I wasn't aware that there were a number of grants to try to get a better understanding of this that went unfunded because of that. I had the feeling that we weren't learning very much because this thing was so easy to kill far away from the AV node, but that was the proof, the real proof that that's the case. Okay, so this is what people call the right-sided pathway, right? So what atrium is this going to connect to, the right or the left? If we call it the right-sided pathway, wrong. It actually connects to the left atrium. Okay, I was just tricking you. It actually connects to the left atrium in every single patient that we've actually looked at. And the way you know this is when you can see retrograde conduction over it. It connects to the left atrium through the coronary sinus muscle. So the left atrium connects to the coronary sinus muscle. The coronary sinus muscle connects to the inferior, to the rightward inferior extension only at the floor of the CS. Now this is strange to me because if you look anatomically, there are transitional cells that go across from the CS here. So you would think you would think, looking at the anatomy, that there would be a lot of connections between them, okay? And that may explain why you get multiple areas of junctional automaticity. I don't know when we do the ablation. I'm not sure, but in everyone that we have looked at, and this has been consistent, and this is over a period of we've been looking at this for probably at least 30 years. The way you look at this is by looking at retrograde conduction. Where does it connect? Okay, and so retrograde conduction always connects to the floor of the coronary sinus in every single patient we've looked at. Okay, so what do I mean? If we were to look at this kind of schematically, retrograde, right? Retrograde conduction. Initially, we're going to have conduction over the AV node. We can't record anything here, right? Then it's going to activate the beginning of it's going to come out, retrograde, it's going to start to do the upper part of the rightward inferior extension. And usually you can't record anything up in here. You can first begin to record stuff down here. The sharp signals are down here, and you do record them in this direction here, and they're the retrograde ASP potential. In the very early days, Michel Hasseguer spent time looking at this, and he looked for electrograms up higher that were smaller and round and kind of far-fieldy looking, and he could find them. But it's not easy to find these potentials or consistent and be sure what you're looking at. It's really hard. So I think I personally haven't pursued that in recent years, and I don't know if anyone else is really is trying to find anything up here. For primarily the reason is you really don't want to ablate anything up here. That's where Michel started after we were talking about the ASPs, whatever. He started looking up here and actually started ablating up there. But I don't know what the risk was of AV block. I hadn't seen anything with that, so I don't know. But it gets sharp down here in this space that we call the inferior triangle of Koch. So that would be the retrograde ASP. Then the first place you see activation in the CS is consistently the floor of the os. And then activation propagates in the CS muscle. Always it goes laterally and up toward the roof. When it gets to the roof, it activates the left atrium. The connection in between the CS and the left atrium is always in the roof. And you remember from that figure, you can see why that was. Remember, all those connections went to the roof. So whenever you're looking at connections between the CS muscle and the left atrium, that's kind of roof area. Okay. Now, these fibers are slanted in this direction. The CS muscle fibers are slanted in the same direction. The conduction velocity is the same. So when you look out here, you see a single potential, just a single electrogram. Okay, you can't tell whether you're looking at atrium or CS muscle. But to come back to the septum, you have to turn around and go perpendicular or transverse to the muscle fibers. So there's a little bit of a delay here. And then you can see the far field left atrial signals coming back this way. So once you activate the septum, then you can cross the septum, and then you can record atrial activation here in your His bundle catheter, right? You can record atrial activation, and you can see the far field signal behind. So now retrograde, you're going to see a sharp potential here and then a far field signal when you have retrograde conduction over the rightward inferior extension. Is that logical? Okay, all right. So we can look at this, and Mark Burnett we've got a couple of CAS's people that operate our Cardos systems that are just absolutely terrific. Mark and Jody, they're unbelievable. And Mark made this and fixed this up for me to show you guys, and it's beautiful. So this is the RAO, and this is a clipping plane. So he cuts off the right free wall, so you can see the septum, and you can actually see activation coming this way. Then it's going to go into the CS, the floor of the os. You can't actually make that out very well because that area is not being covered. But you can see activation coming down here, going into the CS. We should have gotten the floor. We'll do that next time, and show that, right? And here's the CS os. And you can see that once the left atrium is activated, you can see activation going both ways behind the tendon. Do you see that? But you see that's coming left to right. You see it flare. You see here, you'll see it, you'll see it flare right here. It's coming left to right on the true septum and then going up and down, right? Pretty cool? Right? I'll tell Mark you liked it. I hope that's true. I hope that's true. Okay. And here is the way you usually look at it. Okay. This is the same one where you have activation coming here, the floor here, right? And then he'll rotate it so that you can see it from behind. When the left atrium gets activated, we can't see the left atrium. We're not mapping it. But when it does get activated, it's going to propagate back here and flare here on the right side and then go this way and this way. Make sense? So here will be back behind the CS is where you're going to pick up that far field signal. All right, so can we look at this on fluoro and electrograms without a mapping system? Sure, you can. So we're going to do that. Now, in the beginning, we were trying to get an understanding of this in the CS. So in some patients, from an investigational standpoint, we actually put in 2 CS catheters. So we have a CS catheter coming from above, laying firmly on the floor. And then we have a catheter coming up from the femoral approach, and we're pushing up against the roof, right? And you can see the distance here, and you're actually going to see that the timing of the electrograms is quite different between the roof and the floor. Now, the electrograms I'm going to show you is not this patient, because this patient, the ablation catheter is in the fast pathway area. Can you see it's leftward? It's behind the tendon of Todaro here. You see that's leftward. We're going to show you on this coming patient, the mapping catheter is here at the inferior triangle of Koch. Okay, so what we're looking at here is fast, slow AVNRT using the rightward inferior extension for retrograde conduction. So all the atrial signals, all the atrial electrograms will be after the right atrium, after the rightward inferior extension has activated the atrium. Okay, so the very first thing that you're going to see always is you're going to see the retrograde ASP potential. All right, the second thing that you'll see is the floor of the coronary sinus ostium. So, by the way, the electrograms that I'm going to show you all morning, I always put the proximal on top and the distal on the bottom. So the His bundle electrograms, proximal to distal. Here's the inferior triangle of Koch. This is the distal bipolar electrogram. Here's the roof of the CS, proximal to distal, the floor of the CS, and you can see the difference in timing between them, right? Okay, so we activate the floor. These are CS myocardial potentials. They go proximal to distal. You can see that when we come up to the roof is later. Can you all appreciate that? The roof is later, and when you go in this direction, this is both left atrium and CS, and you can see the timing gets to be about the same as you get distally. Okay, now when you come way back proximally on the roof, you see something here that you can just barely make out as far field here, okay? And this is the far field left atrial potentials turning around, coming back toward the septum. Is everybody oriented? Okay, so these are the left atrial signals. They're coming back, and then it's going to go up the septum, go across the septum, and give us the A in the His bundle electrogram, and also the far field A behind the eustachian ridge there. So does that make sense, the activation sequence? Okay, so the key is the first signal, when you have retrograde conduction, and the first signal you see is the retrograde ASP, you are looking at retrograde conduction over the rightward inferior extension. Okay, that's just consistent. Okay, all right. This is also the ablation target. And the cool thing is, whenever you have AVNRT that doesn't use the fast pathway retrograde, that uses a slow pathway retrograde, like in this case, the rightward inferior extension, the good news is in almost always those patients, the retrograde fast pathway conduction is kind of poor. So you can map and ablate during ventricular pacing, because usually fast pathway conduction is very poor. So here in this patient, we're not really positioning this. This was designed to show you the timing of the CS, not to get the sharpest retrograde ASP potential. But when we're pacing and we're getting ready for ablation, we're going to want the sharpest ASP potential, and we're going to want it on the tip electrogram because that's the ablation electrode, right? RF doesn't go back to the second electrode. It doesn't reach it. The RF only kills the area around this electrode. So this is the electrogram that you want the sharp signal on. You want it as sharp as possible, and just like this. And when you get that, as soon as you turn on RF, that's good. It's gonna, if you're touching well, if you have good contact, it's going to disappear pretty instantly. And then you may see some junctional automaticity after that as well. So the target is beautiful. If you can get retrograde conduction over a slow pathway that you know is participating, if you can get that during V pacing, that's perfect, because then you have a definite target. Go.
Could I ask you if?
Of course.
So how often, if you can separate out fast and slow retrograde, how often is that slow pathway actually participate, or is that something that would be a bystander? For
No.
somebody? So could you use
No.
that? So
No.
you use that as a target
In the early
most cases.
90s, we looked at 200 consecutive people that do not have AVNRT. That was people with pathways in the early 90s. Okay, 200 consecutive patients that did not have AVNRT under heavy general anesthesia. The general anesthesia put the fast pathway asleep, and we saw retrograde slow pathway conduction in just a shade under 50% of all people that don't have AVNRT. Okay, if we gave a quarter of a microgram a minute of isoproterenol, the fast pathway woke up and we never saw it. And a quarter of a microgram under deep anesthesia. So we think that, I mean, just that little bit hides it. So we think almost, you can get it in everybody, and it doesn't mean they can have tachycardia. So I fall back to that original question of, why don't a whole lot more people have AVNRT? Because no, just the fact you can see it. Now, I will tell you, and probably we've seen over the years, only about 15 patients that have had multiple slow pathways seen retrograde during ventricular pacing, more than one, a shift from one to the other. And in every one of those patients, they all had not just had AVNRT, they all had multiple forms of AVNRT. So when, for some reason, if you see multiple ones, if you're not getting tachycardia, let them smell at a distance a little bit of isoproterenol, and you will. But just the fact that you can see retrograde conduction over slow does not mean it's arrhythmogenic.
But if they have if you know they have AVNRT,
And you can see retrograde
and you
slow.
can see retrograde slow,
Okay.
is that a good surrogate? In other words,
Yeah, I think it is, but it actually doesn't prove that is the slow pathway that is participating in tachycardia. That's going to be the next talk. How do we work that out? So the answer is maybe. The answer is maybe. Probably, and are we going to take it? Yeah. Because it's the best way to ablate a slow pathway is to be able to ablate it retrograde. You can do it during V pacing at a slow rate, and you get yes, that's the best way. And for instance, you can do this non-fluoroscopically, right? So here's a 10-year-old with slow AVNRT. We made a map here. So what's the retrograde limb? What's the retrograde component of the reentrance circuit in this kid? Well, both are slow. There's an antegrade slow and a retrograde slow. Which one is the retrograde slow? Well, if I ask you this at the end of this talk, you would do better. This map is a retrograde rightward inferior extension because the floor of the os is activated first. It goes lateral and upward like this. This is retrograde rightward inferior extension. Okay, and here you have it, and it's stable, and we have it on the unipolar electrogram. See, it's not on the bipolar. It is on the unipolar. This whole sharp bipolar is all coming from this unipolar. Do you see how the downstroke is on map 1 that times with the bipolar downstroke? Do you see that? Okay, and ablation there instantly got rid of that. Okay, now, so Greg pointed out, yeah, if you can see retrograde slow, that's great. But how often do you get retrograde slow? In fact, all of the, I don't know whether you want to think teleologically or not, but these atrial nodal connections are probably not there for retrograde conduction. They're probably there for antegrade conduction. And so all pathways conduct better, usually you see them antegrade and you don't usually see them retrograde. And the darn fast pathway hides, if there is a retrograde slow, it's going to hide it. The rightward inferior extension, is most often used antegrade. And it's most often used antegrade in slow, fast AVNRT, right? That would be your typical AVNRT, antegrade rightward. And most often you can't see retrograde because if they have slow, fast AVNRT, they usually have good retrograde fast pathway conduction, and you can't find it. You're just going to see the fast pathway retrograde. So you won't have a target for there. So how do you find the antegrade ASP potential? Sinus rhythm, right? Right? And why? For the same reason, there's block across the tendon of Todoro. You don't go across here. The fast pathway goes across in red, but the green, the atrial activation, doesn't come across here, right? So what happens is Bachman's bundle is activated very early and very quickly. It goes across to the left side and down, and this speed is, I'll actually show you a map and show you this, but the speed here is very fast, and these two probably get there at about the same time, okay? But this A doesn't come in here, So this A comes around, and what do you think it activates? The CS. And what do you think the CS activates? The right atrium at the inferior triangle of Koch. And what do you think that gives you? An antegrade ASP potential. So just sinus rhythm, and this is present in everybody, whether they have AVNRT or not, you're going to have an ASP potential. Again, it's present in everybody. All right. Okay. All right. So the key is that this signal is late, and it's later than the timing of activation in the proximal CS, and that's how you recognize it. Now, often there'll be two potentials, a far field and the local, but sometimes you just see the local one. You just see this one, right? So let's look at some of these, okay? So let's look at a map first, and here's a pretty map. Here's another one that Mark made, right? So here's sinus rhythm, and you see activation coming in front of the superior vena cava. So this is the area. So this is Bachman's bundle coming across. So retrograde, if the left atrium activates the right atrium over Bachman's bundle, this is going to be the earliest area activated right here. Do you all see that? Okay. So this is Bachman's bundle coming across. So it's going to, in yellow, it's going to give you the left atrial activation. Okay. So you think, okay, you think the right atrium just comes down like this and should get here very fast. Because we're looking at the right atrium here. Right? This map is of the right atrium. Here's the SVC, IVC, right atrial appendage, CS. But notice, look at the big color jump here. We go from red to green. Actually, it doesn't conduct down like this. It comes around this way. So this takes time. So this is where we have this listed as scar. It's not actually scar. It's just there was no electrogram there, and we wanted to mark that as no electrogram. So we labeled it as scar. Okay. So there's no electrogram here, and we had this labeled on the map, but really it's a line of block all along here. Can you all appreciate that? Okay, right? And so the right atrium comes around this way. Now the left atrium comes down at the same time and activates like that. Of course, it doesn't come this way. It's actually going to come down the septum along a line like that. So during sinus rhythm, the right side blocks. The left side, which we can't see, is this yellow, right? The septum comes down. It's going to come around the mitral annulus, and it's going to activate the coronary sinus, right? And the coronary sinus is going to activate the CS myocardium. Doesn't this look just like retrograde fast pathway conduction? Remember, the atrium got activated here, the left atrium got activated here, activated the CS and comes up. So it looks just the same because of the block across. You see, even in sinus rhythm, it doesn't come across. Do you see that? And again, I don't have an answer for why that is. I don't know why you can go this way in flutter and come out, but you can't go this way. It's beyond me. It's beyond me, but it's just observed over and over, so it's real, and it's good to know. Okay, so here you have a late sharp signal in sinus rhythm, and it's later than the timing of activation in the proximal CS. Do you see that? The light blue, dark blue is later, and then this is later. That's how you know this is the ASP potential. And here you see that this was a 16-year-old. Again, this is also a non-fluoroscopic case, right? And you see this, but you just see one signal and say, well, okay, maybe that's the atrial signal. But look at the timing relative to the CS. It's later. That makes this your ASP potential. Is everybody got that? That's how you find it, all right? And since we want to ablate, what electrode do we want to record it on? This one, right? And which one are we recording it? It's less steep here and it's big and steep here. Can you all appreciate that? It's actually recorded right here. Now, we don't see the far field A on the bipolar, but you can actually see it. And you see how it times near the A and the His? You see the far field A on the unipolar electrograms? It's just too far away for the bipolar, okay? But this, you know, because of the timing relative to the CS, this is the ablation target. So we delivered the first RF. This is RF1 at this site. Okay, so we're pacing the atrium. Here's the stimulus to QRS, stimulus to QRS. Wait, the stimulus to QRS got short here. What's going on here? We turned on RF right here. Sure, we have junctional rhythm. Instantly, you're right on top of that ASP, and it's sharp on the unipolar, you're instantly going to get it. That's a given. Yeah.
I just wanted to, you wouldn't do this until you prove that the right inferior extension is your.
Right. Yeah.
So this is, you already determined.
We're not talking about tachycardia yet. We're just talking about the pathways and how to kill them.
Yes.
Correct. All right. Greg's point is really important. He's saying, wait a second, Sonny, you're jumping the gun. You haven't proven that needs to be ablated. That's the next talk. Okay. So I'm doing these backwards. Yeah. No, it's real clear. So look at this ASP on the bipolar. I have the unipolars turned off because we're going to lose that initially on there. That's why I'm not showing them. Look how sharp and big this is. Okay, and we turn on RF here. What's this? What's this? What's this? These are ASPs. They're earlier than the His. The His you can't see very well in this guy. It's this little tiny thing here, okay? But it's even before the A. Notice the A, and notice the A is proximal to distal. So we have an ASP potential and then proximal to distal. What's going on here? Automaticity. So we're getting automaticity of the rightward inferior extension that's going up to the His and giving us His, but it's also going retrograde. Now remember, this is a kid. You see this more often in children than you do in adults, okay? This is a kid where it goes retrograde. Then the next beat, I should have shown this stops and the A gets later, but you still have junctional. So what's happening in the beginning, what we're used to seeing is when we burn here, we get activation going this way. This becomes automatic. you don't see anything, but you see the hiss come early, right? Here, you also saw it going this way, retrograde, didn't you? Okay, again, it's more common in children than it is in adults. But in adults, if you look at your junctional rhythm, not very often, maybe 15% of the time, the very first beat will also go retrograde like this, and then it'll stop going retrograde, and you'll just see junctionals like that. Okay, but this is automaticity here. You always wonder, why didn't it go both ways? It does go both ways sometimes, especially in kids. Isn't that cool? And so sometimes it's cool to see what's going on. Yeah.
In sinus rhythm, when we are looking for the
ASP.
we have to look at the fast pathway as the earliest activation in the sinus rhythm, right? The fast pathway
No, even if the fast pathway was
present. So how would we know that on the catheters, that's where the fast pathway is, and that's how it's far away from the slow pathway
I
in the
think
sinus rhythm?
we're going to look, hold on, let's keep your microphone there for a second. Let her keep the mic for a second, Greg. And let's look at some electrograms, and then let me see if I understand your question. Okay, so hang on just a minute. So here, notice where we were. I just want to show you the location. If this is the floor of the os and the roof of the os, you see we're low. Okay, you see we're more than 2 centimeters from the hiss. So the AV node is going to be up here, right? The AV node is going to be here. We're far away, right? The radius of the lesion is about 3 millimeters. So we're not going to kill the AV node with this, staying really low like this. I want to point out a couple of things before we get to your question. The first is you do not have to go high in any patient to kill the rightward inferior extension. You do not have to go high if it fails. You want to make sure you have contact. You want to make sure you're covering that area. Sometimes going lower will actually work. I don't ever go, and I never have gone above this level, the level of the roof of the coronary sinus ostium. You do not have to do that. That was an assumption that was made in '88 that came out of the paper from, he was in Milwaukee at the time. He's in Green Bay now. A senior moment again, huh? Is Jazzieri? Yes, thanks. Thanks, Greg. It was Jazzieri's paper where we didn't know anything really about the rightward inferior extension back then. We knew if we ablated low, it works. So he divided it into those regions and said, you want to stay as far away from the hiss as possible. So start as low as you can. And then if you have to, go higher. Everybody took that to mean, okay, if you burn and it doesn't work, just start going higher. And everybody all around the world does this. You understand that this is like cast in stone. Every fellow is taught to do this all around the world, but there isn't a basis for it. There isn't a need for it. I just want you to realize you do not have to do that. And the lower you stay, the less likely you are to make heart block in that patient. Okay, so we're going to be looking in sinus rhythm for the antegrade ASP. So let's look for some of these. So here's one where we actually used the femoral approach for the coronary sinus. And we have it pushed up way high, right up against the roof, so we can see the left atrium. We can see the atrium coming around, okay? We're right up against the roof, so we can see the atrium coming around. We couldn't see that from the floor, right? So with the atrium coming around, you can now see the left atrium here. Can you all appreciate that? It's going proximal to distal. And then you can see the CS. The CS muscle goes parallel with it this way, and the CS muscle goes this way. Okay, this happens in everybody during sinus rhythm. Okay, in sinus rhythm, this is going to occur in everyone. And then you see the timing of the ASP. The ASP is always the signal that is after the timing in the proximal CS. Okay, that's how you recognize the ASP. Even if, like here, the far field is really small, you don't even really appreciate it. You can't appreciate it. Okay, so here's another patient where we're doing ventricular extrastimulus testing. So we're pacing the ventricle, parahisian without His bundle capture, so we can delay the His and delay the A. And you can see we have, with the drive beats, the S1, ventricular S1s, you can see that we have a short HA, we have earliest A in the His bundle electrogram, and the ASP is very late. That makes this retrograde what? Retrograde conduction is occurring over what pathway? Fast pathway, right? Early here, late ASP, that's fast pathway. That's right. And then with the extra stimulus, we have a jump. We have a change in the activation sequence. We have a change in the activation sequence means we changed pathways. Okay? You can have a delay and still be on the same pathway. We have assumed a jump of 50 or more. And by the way, that was a number that was made up in the early 70s. Okay? We assume if there's a jump of 50 or more, we've changed pathways. And it generally is correct. But the truth is, you don't actually know that that isn't just a decrement. Okay? But if you see a change in the activation sequence, that's definite. And now the ASP is first, then the CS, then the His. This is retrograde what? You notice retrograde, rightward, slow was correct, but what I was really looking for was rightward inferior extension. Okay, right. Okay, so now we have sinus rhythm. And in sinus rhythm, we see the ASP and we can recognize it because it's later than timing in the CS. Now ask your question, because here you have a
Yes,
sinus
so
rhythm.
in the sinus rhythm, we need to be away from the fast pathway.
We need to
A,
be away from it.
from the fast pathway. So
So how do you know you're away from the fast pathway?
Yes, that's what my question is.
No, I'm asking you. I'm turning it
I
back on
have
you.
to be, so my atrial activation on the,
Right. So here's His,
Yeah.
right? And usually the fast pathway is going to be about here,
posterior.
right?
triangular.
And what we want to be is in the inferior triangle of Koch, right? How do we know we're in the inferior triangle of Koch and not back here? What view do we use?
LAO view,
LAO. If we're here,
where anterior.
if we're here, we're in the fast pathway area.
Yeah.
If we're here, we're inside the triangle of Koch. We're not anywhere near the fast pathway,
Okay,
and we're low. Do you see why I made that point? The LAO, and you don't have to turn your fluoro on. Your cardio is going to show you the same thing. It show you your catheter, right? It's either going to be parallel. That's why I like you to get all your electrograms sharp on the His, get that LAO angle, put that in your mapping system. That's your LAO. You're in the triangle of Koch, you're out of the triangle of Koch. In the triangle of Koch, out of the triangle of Koch. Everybody's got it. Okay. All right. So this is the target. Okay. Here's another one. Look at the timing. You have a far field signal and a sharp signal, and the sharp signal is after the CS muscle. Right? ASP, this is your target. Here was one from 1987. This was before we even had, this was on a strip chart recorder that was an analog amplifiers. I love those analog amplifiers. I did. Okay, look at the size of this. The huge ASPs are not common. Maybe they're 4% or 2% or 5% out of patients. I don't know what it is, but it's not over 10% of patients. I don't think that give you big, sharp ASPs, but they can be so big. I mean, this is real. I don't turn the gain up. This is not a high gain. I use the same gain settings for everything. All right. But what's classic about, yeah, go ahead, Greg.
I was going to say there was a paper, Japanese paper, that talked about the site of ablation overlapping the His signal because, yeah, okay.
I'll let you comment on that in a second. It's coming. You're ahead of me. I'm trying to build a story. I'm telling it a little bit at a time.
Just look at the time.
Okay, so Greg, but I'm going to give you one that looks worse. Okay. But I want to tell a story. No, I appreciate it. I'm teasing. All right, so this was one of our early ones, and we looked at this, and we looked at the size of the V and thought, gee, are we in the ventricle? Why do all of these? Look back at these. A big V Look back at this, a big V. You see how sharp the V is? Sharp means local, close, right? Why is the V so sharp? The reason is the tricuspid annulus is displaced apically, right? We call this the muscular AV septum because it's displaced into the ventricle. So this is called the muscular AV septum. And so you're right, look what's right underneath you. You're gonna darn well have a big V. Can you all appreciate that? Okay, all right. The second thing is the timing. And the timing is always after the A in the proximal CS. This is your target. You want it on the unipolar electrogram. So here's a kid, and this is another non-fluoroscopic case. This is your case, the case you can ask the question, or you can make your point on. So here are the His bundle electrograms. Here's the A. Here's the His and the right bundle. We call that the His. The sharp part of the His signal is actually the beginning of the right bundle, but we include that and call it His is fine. Now here's the distal bipolar electrogram in the inferior triangle of Koch, and look at these two electrograms. Look at the timing of those two electrograms. I've had a lot of people say, gosh, I saw something, but I thought it was the His, and I was afraid to ablate. So this is what you were asking, right? This is what you were saying. Whoa. What do you do? How do you know you're not on the His there? How do you know you're not on the His there? What are you going to do? The LO is going to be the same because both of these are on the triangle of Koch, or in the triangle, on the triangle of Koch. So they're not going to be back here. They're both going to be here. An extra stimulus or pace, right? Because what's going to happen to the His with an extra stimulus or with rapid pacing? The His and the V are going to move out this way, right? What's going to happen to this? Stay the same. And that's exactly what you do. And that's exactly what Greg wanted us to make sure we covered, right? You were just a minute early. Go ahead.
I was just saying that the timing is such that it's so late that it oftentimes with the His, so you just have to.
Well, and a lot of it depends upon how early the His is, right? This is a kid, and the AHs are not unusually short. I mean, they're short, but we have adults that have AHs that short, and in fact, when I was a fellow 43 years ago, there was my mentor's mentor, who was one of my heroes, a guy named John Gallagher, who defined almost everything between he and Wellens in accessory pathways. Gallagher, when Gallagher was at Staten Island Public Health, he was one of the guys that was there. I won't. John was in Staten Island there, and he proposed. He said, if the AH is really short and it doesn't delay very much, that's probably a pathway. And he gave it a name, and he called it. I'm trying to remember what he called it. He called it enhanced AV nodal conduction, EAVNC, enhanced AV nodal. You don't need to know this, by the way. And so if the AH was 60 or less, and if it delayed less than 100 milliseconds before Winky-Bach, if it AH increased by less than 100 milliseconds before Winky-Bach, he thought that was beyond, that meant there was some kind of connection. And so I spent a year of my fellowship reading every EP study that they had done in Indiana in those days that patient was not on drugs. And I measured the AV nodal curves and plotted them all. And actually, this was just one end of a spectrum. There was no breakpoint. There was no discontinuity or anything in there. And so that was one of the best papers I ever did. Nobody even knows it exists, and it's gone forever, and nobody will ever care. But it's in circulation around 82, something like that. Correct, Cree. Thank you. Did you hear what he said? Do you remember there was a term, Langenau-Levine syndrome, or LGL syndrome? And it was thought that this was this enhanced AV nodal conduction and whatever, and basically it's just one end of a spectrum of normal. So it was not important. Okay. So here you have the far field, the near field, and you know this is the ASP because of the timing. You see the timing? If you're in the triangle of Koch, but you're later than the CS, it has to be the ASP. You got it? Was there a question? Yeah.
When we are differentiating between his versus ASP.
Yeah.
We're giving the extra stem from the his.
From any atrial catheter. Any atrial catheter. Just paste the atrium anywhere. The AH will delay. And this one stays the same. Yeah. And so you separate them. Yeah.
Thank you very much. Honestly, I have tried many times.
Oh, say that loud in the microphone. You need to hear
Does it
this.
work? You hear me? So you will speak about the resetting, right?
Yeah.
Right extension.
Next
left
talk.
Extension.
Yeah.
I actually spent really long time, few hours, and to prove that or disprove where is the integrated pathway.
Yeah.
And then it ended up with slightly, it is wrong, with slightly like what at the level of the CS or slightly up, which is, let's say, dangerous.
Oh,
to
wait,
say-
let's get to the rest of the pathways before you ask that question. Can you save that question for about 20 minutes, 15, 20 minutes?
It works well. I mean,
I know it will
it's
work well.
not- Usually, it's difficult sometimes to prove resetting.
Wa-
So I went.
Was that
back-
when you were in Japan?
No, when I back to Iraq. I was
Back in Iraq. Okay,
yes.
I thought it might have been when you were in
Yeah,
Japan.
yes, I follow your rules exactly,
Okay,
but didn't get it. So my question is,
I think it might have been the
always
anterior superior slow pathway.
but it didn't end up with anyone. It's just successful.
I know.
Yes, I mean when you spend time and didn't get any, and this out of box.
But I'm going to show you today how to do it without spending so much time.
Okay.
So just hang on to that question. Hold that question. I know, and let's see at the end of this talk. Let's talk at the break. And I think I know what you found. Okay. All right. So we want to ablate. We want it on the unipolar electrogram. Can you see there's nothing on the electrode 2? And that signal is all on uni 1. So we're going to go ahead. We're going to go ahead and ablate, and that would be a focal ablation. Okay? All right? And about 30 years ago, Cree Moulton said, well, why don't we make a line? Cree was the first person to suggest that. And I didn't know Cree was going to be here today, actually. He's all the way in the back. He's the guy with the gray hair all the way in the back. I should say white hair. It's nicer, right? We all have our grays, right? But he's the old fart sitting way in the back row, back there. But Cree actually is the first one. But Cree, I think you wanted to do it higher up, if I remember, and it scared me. I do remember, but Cree's idea for a line took hold, and a lot of people like to make a line. I like to do it right at the level of the coronary sinus ostium, and I like to square off go into the CS just a little bit to square off the back of this line. Why don't we ablate on the floor of the os where this thing is coming out? Why don't we ablate on the floor of the os? Because why? Yeah, why don't we want to ablate on the floor? Why is he saying you want to go somewhere else? Why? What's there you don't want to hurt? The artery, the coronary artery. Usually it is the right. Usually it's the posterior. There's a branch of the coronary artery that always comes right up to the floor of the coronary sinus, right where the middle cardiac vein is. Okay. Even in the left dominant system, it's true too, but it's usually the posterolateral branch of the right coronary artery. Right. Okay. So here you can do this, obviously, you can do this fluorously, no problem. As you come back, you're going to lighten the power back here a little bit. And notice here, this circles, these markers are from cardosound. So you can see the level of the os here. Can you see the os? Do you see how we're right at the level of the middle of the os? When you get back here and you come into the CS, back here, 30 to 40 watts is safe in an adult. Okay, in a kid, 30 watts is usually safe here because there's ventricular muscle underneath there, right? But you want to lighten up a little bit as you get back close to the edge of the os, and then you want to be in the 20 to 25 watt range in the os when you do this. Okay, the starting point for that line, most people make that line, it's totally empirical. They just pick a spot and do that. There's nothing wrong with that. If that works, that's fine. What I like to do, and I'm giving you all my biases. Obviously, my talk is going to be a little different than what other people do sometimes, and that's because that's my bias. But I want to share that with you. I like to find the ASP potential, even if I'm going to make a line, and make sure that my line is going to go through it. In fact, sometimes I cheat and will do the first burn of the line on the ASP potential as a focal ablation and then expand it in both directions. The truth is, in all of the years, I'm not sure I've seen a difference in success rates between a focal ablation and a linear ablation. In fact, they both work almost all the time. So, and have very little recurrence rates. So, yeah.
So when you say the ASP potential, what's slightly below it? What's slightly above it? What's the difference in the characteristics of that? Is that electrogram always distinct to you, or is it?
It is distinct. As you get higher up above here, it gets to be very small and rounded. We haven't traced it from the atrium coming out all the way back there, but I will tell you, sometimes we've actually, when we ablated here and it didn't work, we have gotten it from here. We really should try to actually define, answer your question in a way, and get the whole characteristics up in there. That's a really good point. So what I like to do for a line is find the ASP to make sure I'm going to go through it and make sure I go distal to that. So you want to be past it. All right. You want to be on the ventricular side of it for that start, and then and so that you don't miss it. Sometimes if you ablate the tachycardia, if you ablate the ASP, get junctional rhythm, and you still have a tachycardia and it's slower, a lot of times the slower ones are very close. It's an area very close to the annulus. So what about this? So here's the distal bipolar. Here's the ASP. Are we past this one? Is this a good starting point? I have a sharp bipolar then. So say what you were saying. The unipolar does look like it's good or does not? Remember, you want to be past. We're making a line starting at the V end, coming back. I want to be past. Am I past it? Yes. That's it. So what they're saying is, yeah, it's sharp here, but if you look, it's all coming pretty much from electrode 2. The tip has almost nothing on it. So I think we're past it. So we're going to turn on RF. Are we going to get junctional rhythm the instant we turn on RF here? Look at this. Look how sharp this is. No, we will not. We won't until we pull back and get to here, correct? Until the tip gets to here. And in fact, here's the proof. So here's the RF on this case, and you see nothing, right? No junctional automaticity. We start to pull back. We get the ASP on the unipolar one here. And what do you see right after that? Junctional automaticity. That's pretty typical. Okay, so the junctional rhythm speeds up and then slows down and then slows down. It starts slowing down and then it becomes a slow regular rhythm. That's kind of an injury rhythm of some sort. You may be done there. When we see this, we keep it on there for like 30 seconds more for a little overkill. Right underneath there, you don't have to worry. You've got thick muscle underneath there. It's safe. You can spend an extra 30 seconds there just to be sure, and then we pull back very, very. You can do this point by point. Most people like to do it point by point. I like to do it slowly as a pullback, but most people, it's if you're not comfortable, the easiest thing is to do a spot, stop, come back, do a spot, stop, come back to do a spot. But if you do it as a pullback, what you find is sometimes there'll be a second spot of junctional automaticity, and we'll stay there a good 30 seconds again, or 40 seconds, whatever, and then finish the line. And I've always wondered if those secondary sites might be those other branches that come into the rightward inferior extension from the CS, but I don't know. I don't know. All right, junctional automaticity, how often do you see it? Oh, I need to go fast here. I'm running a little bit late. So if you look at 100 consecutive patients targeting the rightward inferior extension, most of these were slow fast. There were some fast slows and slow slows. We saw at least one junctional beat in 95% of the patients, or 95 out of the 100. But we actually saw success in 5 patients out of 100 where there's no automaticity. So it's not 100%, but it's usual.
I saw that those with the high baseline heart rate. Is it common?
High
With
resting heart
baseline
rate.
heart rates. So I thought it's difficult to have junction, even if it's real junction, because the overdrive. I
Could
thought
be. It could be, but no, I think sometimes you can kill that tissue without making, we think it's the heat that makes conduction system tissue automatic. Heat does. If you burn the right bundle, sometimes you get right bundle automaticity, things. Yeah, well, if the overdrive is higher, but usually the junctional rate is going to be faster than even that. But I think that's reasonable. Okay, so notice where we target. We target at the level of the middle of the coronary sinus ostium. At that, we can tell you that the risk of AV block is less than 0.5%, less than 5 in 1,000. Or less than 1 in 200, I should say, patients are going to have block. There's always the rare patient that when you come on there's instantaneous complete heart block. I've seen that once. Everybody I know that's been doing this a long time has seen a patient like that. They never recover. It's permanent. And the anatomy is different in those patients, and there's something different, but we don't know what it is. But most often, this place is safe because the AV node is here. Your lesion is only going to go about this far. It may heat up a little more, a little higher, but the killing effect is only going to go about this far. Okay, so it's pretty safe. So we start this low, but I've watched a lot of other people do this, and I don't know anybody else that actually starts there, other than people that have worked with us and been doing with us for years. Most everybody starts here, and the reason is the eustachian ridge. Okay, coming across here, this thing sticks out in the way, and the higher you go, the less of an obstruction it is, and the easier it is to lay the catheter against the septum. For instance, this is a eustachian ridge from hell. Okay, it's really sticking out, right? You want to get right here for the ablation. Right at this level, here. You have to come up the IVC, you have to come across this, and then you have to get down here, right? Okay, and here, cardosound is really pretty good at this, and it picks up a huge eustachian ridge here. Here, a sheath is really helpful, and you can see picking up the ASP potential. Can you all appreciate that in sinus rhythm? And it's on map 1 and not so much on map 2. So it's perfect. And you can see that the force arrow is sort of perpendicular to the tissue. This is what you want. The contact force is really helpful. Here was a monster eustachian ridge. This was, from cardosound. Can you all appreciate what a mess this is? It's present in kids as much or more than it is even in adults, but it's a real problem. And a sheath is really helpful, and contact force is really helpful because you can make sure your force is perpendicular to the tissue. And everybody looks at this number, marketing put that there. I don't care about this number. I always look at this blue curve, and the blue curve is the force curve. And if the force curve is like this, if it's smooth, you see how like a sine wave it is almost? Do you see that? If it is, that means the spring is moving all the time in the catheter, which means the catheter is touching the tissue 100% of the time. You can get a big number for force with the catheter doing this, okay? What you get is a jerky curve. But looking at that number by itself doesn't give you an answer. That's a mean value. Okay, so you really need to look at the curve, because if you have a curve that like this, I'll show you another one. This is perfect. This means it's against the wall all the time as the heart is moving. All right, here's another one I'll show you. Look at how perfect that is. Now, there's no respiratory variation there because we've shut off the ventilator there. But you can see it's perfect. So here you had 16 grams. Well, that's great. That's great for an average. But if you have a perfect curve like this, even if you have 4 grams or 3 grams, you are touching all the time. That means you can make a good lesion. You just have to compensate for the force. And force is roughly as powerful as power. Force and power are about equal when it comes to making lesion. So if your force is low, but your contact is good, but your force is low, how do you compensate? Power, time, power and time, right? You compensate with power and time, and you get a very good lesion. You can do this with fluoro. You don't have to have a mapping system. Here's a sheath. I kind of like an SL2 sheath a lot of times. And the key for these is what you want to do is you don't want the sheath pushing against the ridge. So what you want to do is come counterclockwise with the sheath, clockwise with the catheter, and then relax it. Let it go loose, and it'll touch. It'll touch. And this is what it looks like on fluoro when it's perfect contact. Watch this. Do you see how that's moving all the time with the tissue? If it moves away from the wall at all, the ridge is pushing it away. But if you're going to be using fluoro, this is the way it should look. That's perfect contact. It's perfect touching. It's perfect touching. You don't know what the force is, okay, but you know you're touching all the time, okay? All right, so the lesion, right, here's baseline. So baseline with atrial extra stimuli, here's the AH interval, it delays a little bit over the fast pathway, then you have a jump to the rightward inferior extension. We knew it was in this case from what we're going to do in the next talk. And we had echo beats or AVNRT here. And after ablation, we have the fast pathway is still intact. The conduction time and the ERP are good for the fast pathway. It's intact, but there's no slow pathway beats. This is perfect. And you see this, and no AVNRT induced even on isoproterenol. How often do you see this? If you go as low as I was showing you, at the level of the middle of the ostium, you see this 25% of the time. 75% of the time, you see this. The fast pathway is intact. In fact, the conduction time is even shorter than it was, and the refractory period is even shorter, so it's enhanced, and that's common. I don't really know why. I know why people say it is, but I've never really bought that argument. I don't think it is real. I don't know the reason the fast pathway gets enhanced when you ablate the rightward inferior extension, but it does. But you still have a big jump here. But all you get are single echo beats, no AVNRT, even with isoproterenol. We've got over 30 years experience that tell us these patients do well. You don't have to do any more. These people are okay. These people are fine. And what people call this, right, they call this a slow pathway modification. I've seen that written on notes coming many times. Okay, so when it says a slow pathway modification, does that mean this is a modified rightward inferior extension? Is that what that means? If you keep ablating at the inferior triangle of Koch, 100 more burns down there, will these go away? No, they won't go away. If you ablate where the leftward inferior extension is, these go away. Okay, and we see that in 75% of these patients, and that's why I think that. So I prefer the term slow pathway ablation targeting the rightward inferior extension to slow pathway modification. Okay, and this is why I think 75% of people have conduction over the leftward inferior extension. Okay, let's talk about the leftward inferior extension. I'm going to go about another 15 minutes. Can you guys make it without a break? Did you have a comment? Okay, I'm going to try to speed up. I'm running really long. All right, so the leftward inferior extension, to figure out where it is, it's easier to look retrograde. It dives leftward and it goes leftward like this, and it either activates the left atrium here and very quickly activates the CS, or it activates the CS and very quickly activates the left atrium. And the truth is, we don't know. No, I've never seen anything that's been shown anatomically or histologically which one it is to be sure. But if you map the right side in the CS during retrograde conduction over the leftward inferior extension, the site of earliest activation is the roof of the CS, about 2 centimeters in from the roof of the os. If you measure 2 centimeters from here to here, something like that. And here you see a map retrograde, and you can see early activation here it gets later distally, it gets later proximally, and it gets later going toward the floor of the CS. And here's what it looks like with catheters. Here you see we have a catheter from the internal jugular. So we're pressed against the floor. We mapped here by putting the catheter very distal along the roof, coming back. It got earlier to here. Then it got later this way, and it's later here. So it gets later this way, later this way, later this way. And here you see that electrogram. Okay, and you see the early A here, and it's like a prepotential here. For the leftward inferior extension, it's not at all unusual to see a prepotential if you can see it retrograde. If you see the leftward inferior extension retrograde, and this patient did have a slow AVNRT using this pathway for the retrograde limb. Okay, and you can see that it's later if you go proximal. Here's the proximal electrode, right? It's later if you go distal down here, and it's later inferiorly, and it's even later in the his bundle electrogram. You all appreciate that? Okay. Now, notice where we're pacing. Okay, we're pacing parahiscine without his bundle capture so that we delay the his. And notice the HA interval is short. It's short. Okay, in the old days, when people said fast and slow pathway, they were defined by the intervals. This would have been called fast pathway, and you would say, oh, you don't want to ablate that. Well, actually, this one you do want to ablate. So you want to recognize the difference, and the difference is based on the activation sequence, not on the timing. Okay, and again, if you have tachycardia that uses this pathway retrograde, usually the fast pathway doesn't conduct very well during V pacing, and you can use it to target. And that's a great way to target. If you have to, you can do an empiric ablation here. And I'll show you 2 examples why you might want to do an empiric ablation. So not all of our patients are young. Here is a late middle-aged patient, right? Late middle age, don't you think? Cree, do you agree? Cree agrees that this is late middle age lady with slow fast AVNRT. And she had a failed ablation prior to being referred to us, and they targeted the rightward inferior extension, and she continued to have episodes of tachycardia. When we studied her, we could only get 1 8-second episode of AVNRT, and that was on the combination of atropine plus high dose for 75-year-old female, 4 micrograms per minute of isoproterenol plus atropine. And we couldn't get it again, so we couldn't do the resetting that we're going to talk about. So we didn't know what the slow pathway was. So we did an empiric rightward inferior extension ablation, an empiric leftward inferior extension ablation, and actually she hasn't had a recurrence. And the way we do this is you want to be very high against the roof and pointing back against the atrium. So you want your force vector, that vector on the force curve, to be pointing up and back toward the left atrium. And you want to go from, if you measure from the roof of the os, and this marker was the roof of the os here, you want to go anywhere from about 1 to 3 centimeters. In this case, we went from about 11 millimeters to 26 millimeters. She was kind of a little lady and got this. This is a case that was very recent that I want to show you something that was kind of important. Okay, and this was another one we had to do empiric ablation on. This was a young middle-aged man 68-year-old guy with bad coronary disease. And he had 2 prior failed ablations. The first one, they targeted the rightward inferior extension. The second one, they targeted both of them. He continued to have tachycardia. When we studied him, he was difficult to induce, but when we did get tachycardia, his pressure dropped to nothing immediately. And we didn't have time to do the resetting. So we decided to do an empiric rightward inferior extension ablation and a leftward inferior extension ablation. Now, the way we did this is we have a CS catheter in on the floor, coming from the IJ on the floor, and we have a femoral catheter up here. If you have 2 femoral catheters, it's kind of hard to work in there. But usually if the one, I thought if you have one from above, it's on the floor, it's okay. And we made a line here, this first line, and I thought we were on the roof. But I saw a couple of echo beats still, and I didn't like that. And I tried getting back to one spot here, and I couldn't get back there. So we said, well, let's just pull the CS catheter out. And we pulled the CS catheter out, and then we got all the way up here to this one. So when I couldn't get here, we got up here, and we could make this other line. Look how much higher. That's real. We know that's real because that ablation catheter has a magnetic sensor. So that's real location, actual location of the tip of the catheter. Okay. And so what I would tell you is if you're going to do an empiric ablation of the rightward inferior extension, I would take your CS catheter out. And that's what I'm going to do in the future to make your line. And then those echoes were gone. Okay. Those echoes were gone. And it was perfect. This was the roof of the CS os. We went from 8.6 millimeters to almost 35 millimeters across there. So pull your CS catheter out once you're in position and ready to do this so that you can get up high. I wouldn't have thought that a catheter on the floor of the CS would have been in our way at all, but it was. Okay. So the rightward and leftward inferior extensions are the 2 most common. And if we look at retrograde conduction, so we have rightward inferior extension, you're going to have activation here first, right? The ASP, and then we're going to activate the floor of the CS, and then the CS is going to be activated laterally and up toward the roof. With the leftward inferior extension, it's going to be earliest here. It's going to go distal, proximal, and inferior, right? Okay, so that's how you can tell them apart. So if now I tell you we're doing this case, and this is the same slide I showed you before, and said this was the 14-year-old with slow AVNRT using, this is the retrograde limb. Which one is this? Which slow pathway retrograde is this? Rightward or leftward inferior extension? Right, rightward inferior extension. That's exactly right. Okay, and you can do this with catheters too, right? You have a catheter on the floor. You start with a catheter on the roof and you come back and see. And now this is the patient that I showed you this from before, where we're going to have 2 CS catheters and we're going to have another catheter in the fast pathway area. Okay, and we're going to do ventricular extra stimuli. And we're going to do it with perihisian pacing without His capture so that we can move the His out and see the A. And you can see that with the drive beat, we have a short HA, and then we have a huge jump with the S2, with the extra stimulus and a change in the activation sequence. And so you're thinking, oh yeah, this is a retrograde slow. And if you look in the fast pathway area, it's definitely late, right? So this is definitely a slow pathway. And if you look at the CS, this is the roof of the CS. This is the floor of the CS. The earliest is right at the os. And activation goes straight this way. Then later in the roof, this is retrograde what? Which one? Rightward, absolutely. Okay. Now over here, we have a short HA. So that's going to be retrograde fast pathway, right? So retrograde fast pathway and then a jump. You agree? Who says yes? Show of hands. 1. Who says no? Ah, look at the fast pathway area. It's late. Can't be fast pathway. The earliest is in the roof of the CS. And when I didn't tell you, that's correct. So what I didn't tell you is the distance between these electrodes, the center of this bipole to this bipole is 7 millimeters. So this is the os, is 7 millimeters in, 14 millimeters in, 21 millimeters in. So the roof is the earliest, 2 centimeters from the os. This is, as you said, the leftward inferior extension. This is the rightward inferior extension. When you see 2 retrograde slow pathways, I will promise you, you are in for, I hope you're not planning to get out of there real quick. This patient had 3 different forms of tachycardia. You know, it's going to be joyous. All right. So you have 2 retrograde slow pathways. You don't see this very often. I've maybe seen it 15 to 20 times. And it's always been a joyous event. So you can't read this, can you? No, this is important. How do I get rid of this? I can get rid of this somehow. Okay. You differentiate retrograde AV nodal pathways by the activation sequence, not the conduction time. Just to show you, well, how important is a catheter on the floor? All right. So this was easy to see the difference between these two, wasn't it? What happens if I take this away? So here's the femoral catheter. Look at the 2 activation sequences. Do they look different to you? They look kind of same to me, just cursorily looking at them. They look pretty similar, don't they? And it's, yeah, Cree. What's the value of the H? It's coming up. It's coming up. So Cree says, can we just use the HA interval? He has a really good point, which we're going to address coming up quick. So the point is that from the femoral, a femoral catheter, these 2 activation sequences look very common, very similar. You can't tell them apart. You have to get at the floor. And so, you know, for me in AVNRT, I always want a catheter on the floor. AVNRT or post-receptor pathways are the 2 times I always want a catheter on the floor. Okay.
Sonny, it also seems like it's got all screwed up, and it's very confusing because we've come up with fast and slow. We stick with these terms, although really it's an anatomic. You've described completely just an anatomic.
That's what I'm trying. Yes, then I succeeded.
We almost need to rename all these things. But I don't know how we.
Yes. Yes. In fact, that's what I'm going to say in the next talk, that we have to think of all these circuits as anatomic. Okay. So notice a slow pathway can have a short conduction time. So Cree said, well, how good is the HA interval? That was his question just a second ago. So we looked at 29 patients that had a retrograde jump and shift in the activation sequence from a fast to a slow. Okay. So, and all of them had retrograde fast. So the short HA intervals were in the fast pathway area. Okay. So this was retrograde fast pathway conduction. Okay. And then all of these retrograde conduction was either the inferior triangle of Koch or the CS roof. So they were either rightward or leftward inferior extension. And the lines are the range. So I put these in the increasing order. In other words, these don't match. The first one on each side doesn't necessarily match the first one on the other side. I just put them in increasing order. And what you see is if you take the longest interval, that is conduction over the fast pathway, and you look over here at how many patients had conduction over a slow pathway in that range or less, it was more than half, 16 of the 29. If you look at the shortest slow pathway conduction time, okay, and saw how many people had fast pathway conduction in that range, it was also more than half. Can you all appreciate that? So there is an overlap. At the very long ends, yes, and at the very, very shortest ends, no question. But I think the safest thing is to not trust the number and always trust the activation time. All right. Now, when people say left-sided slow pathway, they tend to think of the rightward inferior extension, the one that we just talked about. with the earliest day here, and ablation from the roof of the CS, right? Okay, but there's actually a farther leftward pathway that's less commonly seen, far, far, far less commonly seen, where the earliest day is in the left atrium, close to the annulus, somewhat close, 5 millimeters or so. And it's always 4 to 5 o'clock in the LAO projection, almost always right at 4:30. Almost always right at 4:30. This does not use the CS as part of its, you cannot kill this from the CS. Okay, the CS is activated secondarily in this one. Now, like all of the slow pathways, retrograde conduction is rare. Okay, usually these are, gosh, I wish I knew how to get rid of this. Usually this is going to be used antegrade in slow fast AVNRT, and you don't see any retrograde slow pathway beats. We never knew this existed until we saw one that conducted retrograde, and we could map it and see that this didn't match anything else that existed. And I've only seen three that go retrograde. Most of them go antegrade. We've done 10 that go antegrade, 3 that have gone retrograde. And the first one that went retrograde to tell us it existed was in 1995. Okay, and it was a patient with a fast slow AVNRT that was sent to us after 2 prior ablations, and they ablated the heck out of the coronary sinus. It wasn't the word they actually used when they called me on the phone. They used a different word, but it was sort of similar in meaning. They burned and burned and burned in the CS, and you can actually see the multiple areas of block here in the CS. So we induced it with an atrial extra stimulus. We see a huge jump antegrade, so it's an antegrade slow conducting to a retrograde slow with earliest A in the posterolateral coronary sinus, And when we watched it, notice right away the AH is shortening. Do you see that? And then it abruptly shortens, right? And notice this one blocks distal to his, no ventricular activation. So we exclude ventricle. When we entrain this tachycardia, we have the exact same activation sequence. So this is not an atrial tachycardia, all right? This is not an atrial tachycardia. We can pace the ventricle and get this exact activation sequence. So this was a form of AVNRT. They had ablated extensively in the CS. So we went to the left atrium, and just a tiny bit earlier than what we have in the CS, we found it in the left atrium here at about 4:30 o'clock. All right. And notice this was the earliest that we found. And you can see local activation. The first rapid of the bipolar is here. If you look at the unipolar electrogram, it times the same. Do you see that there's a far field part with the wave? Do you see on the unipolar the wave coming towards it? You see the R wave coming toward it here. This little upstroke coming toward it. And that is 7 milliseconds long. Normally on a focal rhythm, I try to be within a couple milliseconds of onset. Okay, so no, here we have a far field that's that long. So we didn't know if this would work. And the first burn that we turned on, you see on the third beat, it's blocked. Okay. All right, so that's the very first one. That told us this existed. So we started to look antegrade for these as well. And that's when we found them much more often in slow fast AVNRT that we're going to talk about. But here's the last one. Here, and this was a non-fluoroscopic. Here's a 14-year-old kid with slow AVNRT using the rightward inferior extension antegrade, and we'll talk about how we knew that in a few minutes and when we come back from the break. And the leftward and infralateral left atrial slow pathway retrograde. Here was the earliest activation, and it looks exactly the same. There's a little tiny far field. You see the activation time is this vertical line, and it matches on the unipolar. Oh, let me get rid of this here now. I have to keep moving this. Okay. You can see the downstroke matches this on map 1, the distal unipolar electrogram. But look, there's a far field component that begins here with the red line. That's 8 milliseconds long. but one burn here also worked. And the question is, why don't we find earlier? Now, one problem may be that we didn't get with the pen array, we didn't get down lower a little bit better. Maybe it was a little lower, or maybe, but both of these were the same. Maybe it's deep. Maybe it's deep somehow. I don't know, but the burns work. And you can see sometimes immediate response. So it can't be super deep. I don't know, but the times we have seen retrograde, we don't get within 2 milliseconds of the onset. It's interesting. I don't know, but that's the infralateral left atrial slow pathway. And then very quickly, right before the break, the last thing is this very rarest of all of them, the anterior superior slow pathway. And you see that retrograde, the earliest A is going to be behind the tendon of Todaro. So it's going to be right near his bundle electrogram, right? So it's often mistaken for retrograde fast pathway. It's often called unusual typical AVNRT, meaning slow fast AVNRT, as though this is actually a fast pathway. And let me show you an example. The way you know the difference between this is higher than the level that you record the proximal his bundle potential. If it was really the fast pathway, it would be lower. Okay, let me show you an example. So here with burst pacing, we get an echo beat. Okay, and in this echo beat, the A is earliest in the hiss. So you might say, well, maybe it's a funky fast pathway with a long conduction time, right? But then you look, you move the catheter up higher here. Here's the RAO with the clipping plane. Here's the hiss, and the proximal hiss is here. So we're behind the tendon of Todaro. Here's the ridge. Oh no, I'm sorry. This is the CS. So the ridge is this way. The ridge is this way. Okay. We're behind the ridge. We also know we're behind the ridge because we're leftward in the LAO, or lateralish. Do you see that? Okay. And we're higher than the hiss. Do you see that we're higher than the hiss? And it's earlier. Can you appreciate that? It's earlier, higher than the hiss. Now, it's true the HA is a little bit long, and it typically is long, but what we're going to go into in the next talk is why, when you have retrograde conduction over a slow pathway, the HA changes with the echo beats or tachycardia. It's variable. It doesn't happen in slow fast. It can be short like this. The A could be here, or it could be here, or it could be here on different episodes of tachycardia. That tells you it's not fast pathway, just that alone. But here now we know it's not fast pathway because we mapped up higher, and we know that this is the anterior superior slow pathway. Okay, so this is often, and you're going to see this, they're going to call this typical, unusual typical, or something. It's not. It's slow AVNRT using this. And the reason that HA varies is the lower common pathway. And I don't want to go into it now, but I'm going to explain it on the next talk and why that tells you it's not slow fast AVNRT. Okay, and actually ablation here worked. But I want to show you the location. This location, look up here. What other tachycardia occurs right at that spot? Does anybody know? Yeah, a lot of people call it septal atrial tachycardia. They call it septal, but it's not really in the septum. It's up high like that. The septal atrial tachycardias typically occur in this exact same location. And I kind of think that it's the same tissue. I think it's the identical same tissue. And if you look where that is, it's on the thick part of the septum up here. If you make a cut here, like Sam Asirvatham did, make a cut here and look, you see it's very thick here. And those atrial tachycardias, when you map them, and you map on both sides of the septum, they're not exactly on one side of the septum. They're deep, and there's an R wave on the unipolar coming towards the activation on both sides, but one side is earlier than the other. If you ablate on that side, that side, it will work. But look at where, do you know which cusp this is? This is the non-coronary cusp, and look where it lays. And so we've changed from mapping the atrium on these atrial tachycardias and going on both sides to actually ablating there. And actually, that's what people have been doing for these pathways. Okay, and this is the pathway that I showed you. Here's where we had earliest activation. Here is the reconstruction of the aorta from the cardosound, and here's the back of the cusp. The back of the cuspling. Look at the proximity. Do you see that? Pretty cool, huh? Pretty cool. So these are the forms of AVNRT. You hear people talk about ablating AVNRT from the non-coronary sinus. That's the form of AVNRT that's ablated from the non-coronary sinus. So this is the story, a half an hour late. So we're going to take a short break.